Welcome, everybody. Rush University Medical Center Division of Nephrology Renal Biopsy Conference for August 18th, 2022. Today we've got a case by Dr. Gashti. We do not have an activity code, a CME activity code. It's a little bit delayed. If anybody is counting on CME, just send us an email and we'll have it in a couple of days. We'll send it to you. These are all being recorded and uploaded to YouTube, to our YouTube channel by Dr. Baxi. So you can always go to our YouTube channel and see some of our, I don't know, we must have 100 up there by now, conferences. If you're not on the email list and want to be on our, just throw us a comment in the chat room, either one directly to us or general, it doesn't matter. Throw us an email and we'll put you on the mailing list. Invite all your friends. The more, the merrier. Use the chat box. Everyone else is muted. We'll try to get to your questions in the chat box. Certainly, if you're a co-host, pipe in at any time. I know none of you are shy. We have nothing to disclose, and to ensure patient privacy is preserved, identifying information have been changed to disguise the identity of the patient and to protect patient confidentiality. And with that, let's move on to the case. I think Dr. Gashti is going to read it for us. Casey?
All right, so this patient is 65 years old. She's a female. She has a pretty extensive history of cardiac disease. She's had multiple angioplasties. She actually has 5 stents. She has had a TIA. She had Graves' disease, status post-radioactive iodine, with post-iodine subsequent hypothyroidism, multiple episodes of GI bleed. She has fibromyalgia. She presents with progressive lower extremity edema and associated fatigue for the past month. She states that she's been taking ibuprofen, 400 milligrams, approximately once a week, never more frequent than that, nor does she take any higher doses. She told me that her GI doctor had warned her about NSAIDs because of all the repeated history of GI bleeds. She takes gabapentin and baclofen for fibromyalgia. She received her COVID vaccines over a year prior to this presentation and had not had any plans to get boosters. Her daughter reports that her mom had not been herself. She was very tired. She was having dyspnea on exertion and lightheaded to the point where she would have to use a wheelchair to get around, and that was very unusual for her. She followed up with her endocrinologist, assuming that her symptoms were due to her thyroid dysregulation. In fact, she did have a very elevated TSH to 120, so her Synthroid dose was adjusted. However, her edema and her fatigue persisted, so she ended up coming to nephrology. Her past medical surgical history, as I mentioned above, she does get migraines. She has rectal bleeding as well as internal hemorrhoids. She has had colonic polyps. She has reflux disease. She has optic neuropathy with right visual field loss. She has a pseudo Foster-Kennedy syndrome, which is essentially increased intracranial pressure with a compression of the optic nerve and contralateral compensation. She has had multiple knee and ankle and hand surgeries. She's an avid bowler, so she's had a lot of bone and joint issues. Social and family history is significant for a 20-pack-year history of smoking. She quit 25 years ago after her first MI. She drinks occasionally. She's allergic to sulfa drugs, latex, and epsiximab, which is a G2B3A inhibitor. This is, I assume, was given to her during one of her episodes of coronary disease, and she actually had a seizure with it. Medication-wise, she's on Synthroid, pantoprazole, thiamine, aspirin, atenolol, atorvastatin, CoQ10, eye drops. She's on ezetimibe, gabapentin, baclofen, and ibuprofen on as needed basis. Her physical exam, she's hypotensive. This for her is low. She usually runs 110s, 120s, 90/60. Heart rate is 114. She's 4'9" and weighs 130 pounds with a BMI of 27. Her exam is really remarkable for the fact that she appears just very pale and exhausted, and she has significant bilateral lower extremity pitting edema. None of these meds are new, as came up in the chat. Her sodium is 144, potassium is 3.5, chloride is 113, bicarb is 23, BUN and creatinine are normal. Total protein is 3.7, albumin is 1.9. Of note, her serum albumin was 4 about a year ago, and it was 3.3 6 months ago. Calcium is 7.7, her LFTs are normal. She has a normal CBC with a normal diff. Hemoglobin is 15. Her cholesterol is 547 with a triglyceride of 290 and an LDL of 412. Her ANA, double-stranded DNA, ANCA were all negative. Her complements were normal to actually elevated. Her PLA2R was negative. Hep B, Hep C, HIV, and COVID were all negative. SPEP and UPEP did not show any monoclonal immunoglobulins. Her UA had 4+ proteinuria, 1+ blood, 4 RBCs, and 10 WBCs, and the quantification of her urine protein to creatinine ratio showed 9.7 grams per gram. Her renal ultrasound showed a normal sized kidneys bilaterally. She had a 3 millimeter non-obstructive stone on the left. So a percutaneous renal biopsy was performed.
Any questions for Dr. Gashty?
Yeah, any antithyroglobulin antibodies by chance, or?
No, I didn't have those. She sees an endocrinologist at a different hospital, and he's been following those, and he's been adjusting her meds. I did not check those.
Casey, did you do a free light chain ratio or just the serum?
No, I
urine?
did. No, I just did an SPEP and UPEP.
Okay. And weight loss?
No, she's actually had weight gain.
Okay.
She had, I think, about 13 to 14 pounds of weight gain in the past month.
Okay. Well, we're going to start with a poll here. Anybody that's not a co-host can vote. So your voting is anonymous, so I'm not going to call anybody out. So what do you predict the pathology will show? FSGS, number 2, PLAR2 antibody negative MGN, associated with Graves' disease, minimal change disease, or minimal change disease with acute interstitial nephritis from her non-steroidal use.
A minute here or so. Again, it's anonymous. We can't really see what you choose, so get it in. And there's a couple more that hopefully that's probably pretty good. We'll end the poll here.
All right. Well, we've got a smattering of answers. We got 10% said focal sclerosis, 41% PLA2R antibody negative membranous, 26% said minimal change disease, and 23% said minimal change disease with acute interstitial nephritis. Steve Corbett, this is right up your alley. You want to walk us through your thoughts on this case?
It could be any one of those things.
Okay. Dr. Whittier, do you want to?
So I apologize. I can't remember the whole UA. Did the UA have anything more in it than protein?
Had trace blood and I think 5 red cells.
No, yeah, no, just protein and 1+ blood, 4 RBCs.
But it did have white cells in it. I was trying to get the interstitial nephritis part of it.
It had 10, yeah, it had 10 white cells.
Because the creatinine itself was quite good at 0.7. Yeah, I mean, her weight increase is probably because of this edema, I would assume. Literally any one of these diagnoses would work. I mean, FSGS, it would be more the tip lesion. If she had that, I don't think that's what we're going to see.
Why do you say more likely a tip lesion?
Because she's got normal renal, her creatinine's 0.7. If she had, NOS or collapsing FSGS, I'd expect her to be hypertensive or more hypertensive. She's actually got a low blood pressure. And I would expect that, she'd have some renal insufficiency. I guess you don't have to, but generally you do. But the patients with the tip lesion kind of present like minimal change disease. So that's kind of why, because to me, that's what this is looking like.
So let me ask you a question and clear this up for me because I might be a little confused. So I think of when I think of tip lesion versus not tip lesion. If you have a tip lesion, so FSGS with tip lesion is what you're saying?
Yeah.
So
if she had FSGS, this would be
So,
more
okay.
consistent with the tip lesion presentation than it would
So
be.
my understanding of the tip lesion is that if you have FSGS and you have the tip lesion, you're more likely to respond. But is someone who has this sudden onset kind of minimal change focal sclerosis overlap syndrome, are they more likely to have tip lesion? Do you understand my question?
Not really, but the reality of it is that the presentation is the same. It's just that you could have minimal change disease or you could have FSGS with the tip lesion. They look the same. It's the histology that's going to define which one we're going to be talking about. And they essentially respond the same. It's so.
I understand, but you're saying then that FSGS that doesn't have a tip lesion, it doesn't have to be perihilar either, but somewhere in the middle. That's not gonna act like minimal change.
No, it doesn't. It generally doesn't. I mean, NOS FSGS usually presents with, they'll have hypertension, they'll have more hematuria, they'll have microscopic hematuria, they'll have renal insufficiency usually. Collapsing FSGS, usually significant, severe, used to be called malignant FSGS in the days of Stuart Cameron and others, would be, severe hypertension, proteinuria, and yes, it'd be massive proteinuria, but they would also have, significant renal insufficiency early on, more often than not, unless you catch it really, really early. Perihilar FSGS, which usually goes along with secondary FSGS, those are the ones that present usually more indolently, and they're secondary often to other things, whether it be hypertension, reflux, or things of that nature. So in my mind, these things, although there's always exceptions, have different presentations. At least that's how I think of them in general.
No, I think that's absolutely spot on. I just had never, and thanks for pointing it out, never realized that if someone with focal sclerosis has what we consider primary focal sclerosis and that looks like minimal change, you're saying that's pretty much tip lesion, period.
Yeah.
Yeah. Okay.
The way I view it, at least. So that would be that. I think minimal change disease fits beautifully with this, for the reasons we always talk about. She's got relatively recent onset proteinuria, edema. She's got significant hypoalbuminemia. She's got a lot, 10 grams of protein, and she's extremely hypercholesterolemic. And we get into this discussion all the time about what that means. But, at least for me, that kind of classically seems, that's the presentation I think of with minimal change disease when we see it in its kind of purest form, if you will. Could it be interstitial nephritis? Yes. Minimal change from NSAIDs. I mean, that's always a possibility, when years and years ago, when Greg Warren and I were looking at this in our own population, you can get minimal change disease from NSAIDs without even having interstitial nephritis. What tells the difference will be how quickly it resolves when you stop the NSAID. But you can definitely have an interstitial nephritis. I would have just expected that the creatinine might be a little higher, but it doesn't have to be if you catch it early on. As we've talked about before, the interstitial infiltrate's usually lymphocytic. You can occasionally see eosinophils, but it's more often lymphocytic compared to other forms of interstitial nephritis from antibiotics like prednisone or cephalosporins or sulfas, which are much more eosinophilic, or even PPIs, which she's on. PLA2R negative membranous. Yeah, that's a good thought. I mean, that's why I was wondering about the antithyroglobulin antibodies, which I think oftentimes you might see. It's possible. It's always possible, but I just think this kind of more sudden onset makes the membranous a little less likely, but she's in the right age group. You can have some microscopic hematuria with membranous. She doesn't really, 4 red cells. The DIP6 positive is 1+, so we'll assume that's probably more representative than the actual microscopic, which if it wasn't if the microscopic wasn't done relatively quickly after the urine was provided, which if it was sent out, those red cells could have lysed. But anyway, membranous is still a possibility that's PLA2R negative. But my bet, based on the things I've already said, is minimal change disease. And then the question is it primary or secondary? Well, the only thing I could think of being secondary to right now in her would be the NSAID, but as Casey said, she really doesn't take it that frequently. The only other thing is whether she has a lymphoproliferative disorder that's kind of brewing and we just haven't found it yet.
Can I ask Steve and the other discussants a question?
Absolutely.
Uh,
Oh, boy.
Hypothetically, if the urinary albumin to creatinine ratio indicated that 95% of the total protein was albumin, would that change your differential diagnosis?
Yeah, that's that. Yeah, I think I know what you're getting at. You're looking at it, you're saying it in a different way, but if we're talking about more selective proteinuria, I think that's what you're heading for.
Yes.
People don't do it anymore. It used to be what, IgG to transferrin ratio or something that they would measure. But I've never thought of it in the way you just described it, but that's pretty slick. Yeah, I mean, if this was predominantly albumin, then I would say by all means, minimal change, which is, as we always talk about, being much more selective than things like membranous or FSGS. Years ago, I think it was, oh my God, I don't, not Ponticelli, but in Milan, Giuseppe D'Amico, talked about steroid responsive renal diseases, not just minimal change, but also FSGS and membranous, and showed that in those patients, the more selective the proteinuria they had. So even even FSGS and membranous can have more selective proteinuria, but the more selective the proteinuria was, the greater the likelihood that they would respond to therapy, if I remember that paper right. So for sure, it's most classically associated with minimal change. And so to answer your question, Dick, yeah, I would say if it was really selective, I would make my selection of minimal change disease even higher than it already is.
Hey, Casey, well, do we
Yeah,
have
I think there is a continued reason for looking at selectivity in patients who present like this, because studies done in the late 20th century indicated that a urinary transferrin to IgG ratio of less than 0.2 was 95% sensitive and specific for diagnosing minimal change disease in adults. And the corollary of that would be, of course, a very high albumin as a percentage of total protein as a rough guide to selectivity. And I would say if this patient's albumin to creatinine ratio were 900 milligrams per gram of creatinine, the diagnosis would be minimal change disease.
It's interesting you bring this up because it's kind of something of our era, I guess, back in the 70s and 80s and even before, where that was really talked about a lot. And since then, at least my impression is, Dick, and I don't know about yours, people almost never talk about it, but it's not as if its importance doesn't still exist. I don't know that I ever see anybody, writing about looking at that anymore, but I think you bring up a good point. It may be worthwhile kind of resurrecting that whole evaluation.
And it is interesting thinking about it just a step further. You wonder if that would also correlate to the degree of podocytopathy. Membranous can have diffuse effacement versus not, and focal sclerosis, of course, diffuse effacement versus not. Minimal change almost, exclusively has diffuse effacement. But you wonder if the membranous ones with the diffuse effacement have more selectivity, or the classic primary FSGS with total foot process effacement may have more. And maybe that selectivity really points, towards getting more specific and at the podocyte itself. I don't know that. I'm just wondering if it'd be interesting to go back and take a look at those biopsies.
Yeah, I mean, it's interesting you bring that up, Bill. I mean, the fact is that in membranous, they classically had fairly non-selective proteinuria, despite the fact that they would have massive proteinuria.
Nico said that even the membranous ones with more selective were more steroid responsive, and the FSGS ones with more. So I'm wondering if those ones that were more selective also would be correlated with DFE.
Oh, no, I understand what you're saying. But what's interesting is what you've shown before is that the proteinuria in general correlates to the foot process effacement, if you will. And it's not saying it wouldn't be worth looking at. I think it'd be definitely interesting to look at. But in those patients, classically with nephrotic syndrome and nephrotic, those patients generally had non-selective proteinuria. Now, whether they, I'm
Yeah,
assuming.
but a low serum albumin level does not tell you anything about what the urinary protein selectivity is.
Oh, no, I agree with that completely.
Okay.
I know, no, I'm getting at a different point with Bill, but either way, for sure, the more selective the proteinuria, even in membranous and in FSGS, the more likely, at least from what D'Amico showed, is that will respond. Whether there's a correlation would be an interesting thing to go back and look at between the foot process effacement and membranous and the selectivity. I mean, does anybody here besides Dr. Glassick remember the last time they ever did a transferrin IgG ratio? I mean, I think I did it when I was a fellow and maybe early on, but I don't know that I've ever done it after that.
But
I
there's
think
no
part-
reason why his suggestion of a protein creatinine ratio and a simultaneous albumin creatinine ratio might tell us the same thing. We do this all the time. And,
We do, but I don't know.
We do it
but
the
I
other
don't know what
side
the-
of it.
Well, what are the break? We don't know what the break points are for that unless Dick, is there a paper you've seen that looked at albumin creatinine ratios relative to total protein creatinine ratios and come up with a break point as to what the ratio between those two needs to be?
Well, greater than 95% albumin in the urine in a nephrotic patient would be a strong indication of highly selective proteinuria.
I mean, I would think 90%. We never see anything close to that. And we check a lot of times, and we usually check it for the opposite reason, looking for proteinuria, the other side of that, where it's low levels of albuminuria and indicating this, tubular interstitial disease. So we do order a lot of them simultaneous, but it's a really interesting point.
Yeah.
Now, tell me something. I mean, I haven't thought about this in years, and I'm a little embarrassed to ask, but, nothing stops me here, but as I remember, it was thought that about minimal change was more selective because of the loss of the negative charge in the heparin glycan within the basement membrane. Is that still thought to be so you'd have heparin being negatively charged, it would repel it, and is that still thought to be the reason why it's so selective?
Well, that hypothesis is still plausible, and a lot of the early data would support the idea that in minimal change disease, there is a diffuse loss, not just in the glomerulus, but in many other capillary beds of negative charge, which allows albumin to leak out into the extravascular space and is at least in part responsible for the low serum albumin concentrations. Enormously low serum albumin concentrations seen in minimal change disease. I've seen serum albumins of 0.5 grams per deciliter in a patient with minimal change disease. That never happens in membranous nephropathy, and I don't think I've seen it very frequently, if I can't recall, in anything other than collapsing FSGS. Now, I'm not saying that we should resurrect protein selectivity, but in a patient like this, if you really think you need to know before you do a biopsy, perhaps looking at the albumin to protein creatinine ratio might have some utility, but I'm not making a big case for it.
Well, let me ask you this, Dick. I mean, let's say we did it and it was 95%. Would you ever feel comfortable going with that alone and not biopsying?
If there was a contraindication to a biopsy, possibly a single kidney or the patient on anticoagulants, I would treat a patient in that circumstance with steroids without a biopsy.
Yeah, I mean, that's kind of what the pediatricians do anyway, but it's obviously for different reasons and different differential diagnosis.
I mean, I guess you could make an argument that in somebody like this that has otherwise normal renal function, you have her, we've done this in the past too, right? We have them stop the NSAIDs if you really thought that was it and watch them for a week or two, depending upon how symptomatic they are. You could also, in addition to that, just go ahead and empirically put her on 60 of prednisone or whatever the dose would be and see. I mean, you could make an argument for that. For sure, if there's a contraindication, as Dick said, you could definitely make a strong argument. But I guess even without, if the patient was balking at doing a biopsy, given everything else being negative and a renal function being quite good, I mean, creatinine 0.7 is pretty damn good. I mean, you could do that. I mean, I agree that I think the biopsy is still valuable for sure, but you could make that argument.
I mean, I'm a little surprised that we don't make that argument a little bit, like the pediatricians do. We're moving towards that with PLA2R positive membranous. I've seen good arguments to not biopsy somebody with a positive ANCA whose clinical disease is strongly suggestive of vasculitis, especially if they're going to treat them, if the treatment's already decided. I mean, when I was a fellow, the thought of not biopsying somebody was just, people would be aghast, of just assuming what you have. And, I think we ought to keep an open mind on this stuff.
Yeah, well, since we were all fellows, a lot has changed. I mean, there are markers we didn't have before. And I think that's the point you're making. I mean, we have other markers.
Yeah.
But Roger, this patient also has features of plasma volume depletion, low blood pressure, tachycardia, a slightly elevated hemoglobin concentration.
Yeah.
That almost never happens in membranous or in FSGS, despite severe nephrotic syndrome. They generally present with volume expansion due to primary renal salt retention. Minimal change disease is about the only circumstance where you can see features of volume depletion in association with nephrotic syndrome. I mean, in this patient, for example, if the plasma renin level were, 20 times normal, which I would also suggest that would be a feature of minimal change disease. Actually, Metzger looked at that many years ago and found that plasma renin activity was a very good way to separate minimal change disease from other forms of glomerular disease causing nephrotic syndrome. Obviously, I'm not suggesting that a plasma renin activity would be a diagnostic test, because this patient's going to get a biopsy no matter what.
But I think that's a really good point, because there is a fundamental difference, and you made the point, but I'm going to say it again, between the edema of all glomerulopathies, which is primary sodium retention related to proteinuria, stimulation of the ENaC channel, as opposed to minimal change disease, and the intravascular volume status is very different between the two. And your point, whereas minimal change disease, patients are often hypovolemic. It's probably why we see ATN so frequently associated with it. It's abrupt, and even your point where, that your albumin loss is not only in the kidneys, it might be throughout the body, not only explains the degree of hypoalbuminemia, but the abruptness of the hypoalbuminemia, and possibly the hypovolemia, because, and the edema, the abrupt onset of edema. So I think these are all really good points. And in the chat board, yeah, the overfill hypothesis does not hold true in minimal change disease. And I think it is the one relevant underfill in our, really in nephrology is classic for minimal change disease. So I think let's go on, let's spin the wheel and see what we have. Well, it's Dr. Gashty, but this is his case. So, oops, it's Chintov. Funny how that worked. It bounced right back to second-year fellow.
Hold on, Chintov. All right, you should be able to unmute yourself now. Go ahead and test out your audio.
Can you hear me?
Yeah. Yep.
Hi.
I'm going to share the screen. I'll give you controls. Remember, there's a lag. So just give it a second. Let's see, 1 second here. Okay, go ahead and click on the screen. Yep. And you see it on the left corner. Yep. You can keep on going.
All right, so this is the trichrome stain. We're looking at a good core here. I see a lot of gloms in there. Not a lot of blue staining material. The tubules are packed back to back. Don't see a lot of blue staining material. Overall, a good core. Not much fibrosis. I would say like less than 10%.
I think you're breaking up quite a bit, Shintop.
Hey, Chinta, we can't hear you that.
Yeah,
Yeah, your
but I
connection's
heard
bad.
you
Your
say minimal fibrosis. I agree with that. It looks like a good preserved cortex.
Okay, sorry about that.
Yeah,
Hopefully
I
it's a
think if
little
you turn
better
your
now.
video off, you might project better. It sounds better now.
All right, so this is a H&E stain. We're looking at one glom right in the middle of the screen. Looks really good. I don't see a lot of abnormalities. I don't see mesangial expansion or mesangial hypercellularity or endocapillary proliferation. I know FSGS was also in the differential, but I don't see like a segmental scar or anything like that. So it's an overall a preserved glomerulus. I don't see any abnormalities in there.
Good. Yeah, we got the hilum at 5 o'clock. I agree. There's no lesions.
Okay, so now we have a ES stain here. We're looking at two gloms, and I'll start with the one on the left side here. Again, it looks really good to me. I don't see any segmental lesion or scarring. The capillary loops look open. And not a lot of cells here. So overall, an intact glomerulus here, or glomeruli. This one here is the second one here, and that also looks pretty normal to me. Maybe a little bit of more hypercellular here, but overall, the capillary loops look open. No endocapillary proliferation or mesangial hypercellularity, maybe except this area here and maybe up here, but overall, it's a normal looking glom. Looking at the tubules here, I don't see a lot of, the brush border looks preserved. I know this is the same we look for ATN. So not much ATN as well. So overall, normal looking glom and tubules.
Yeah, no interstitial nephritis.
Correct.
Yeah, I agree. Normal so far.
Okay, so we have a silver stain or Jones stain here, and we're looking for spikes or holes or any break in the basement membrane. And we had membranous as our diagnosis as well here. So let's see if I go along and look at the glom here, I don't see any break in the basement membrane. If I look closely, I don't see any spikes or holes anywhere. So I think overall this looks like a normal glom with no holes or spikes or.
I think this renin level is just going up and up and up as we move on.
So on IF, the IgG was negative. So I'm assuming it was everything was negative, Dr. Symbolic?
Yes, everything negative. So that excludes membranous nephropathy.
Yep. All right. All right. So we have EM here. Just to orient ourselves here, the blood space, urinary space. We got. So we're looking here for any deposits. So this is the basement membrane. If you look along here, I don't see any electron dense deposit. They look pretty good. Now looking at the foot process here, as I go along the basement membrane, I do see like diffuse foot process effacement all the way going in here. Nothing in the mesangium. I don't see any electron dense deposits here. Here also I see some diffuse foot process effacement, and same up here as well, diffuse foot process effacement.
Okay, I think you said foot process effacement, so I'll agree with that.
Correct.
Diffuse.
We can say whatever we want because this is a bunch of mumbles.
Okay, so this is another EM here. We have the blood space here and the urinary, blood space here, urinary space here. Again, we're looking at the foot processes. As I go along the basement membrane, again, it looks diffuse foot process effacement. No electron dense deposit either in the basement membrane or in the mesangium. Same here, diffuse foot process effacement all along the basement membrane. No electron dense deposits that I see here. So far, it's basically diffuse foot process effacement throughout.
Yep, good. And we'll get a measurement of the GBM.
Okay, so GBM was 339, so that is normal.
Yep.
Again, if we look here, still I see diffuse foot process effacement all along.
Yeah, actually at the top, those are red cells. So you can see
Okay.
the fenestrated endothelium just on the other side, on the top side of the GBM. Yeah, those are red cells. Yeah.
Okay.
So the podocytes are there, yeah, where the arrow was. Yeah, that's endothelium. On the
Okay.
other side are the podocytes. Yeah.
Got it.
Yeah, which are diffusely effaced.
So another EM image here. So the GBM is 324, so that's normal. Again, nothing along, no deposits I see here. Again, diffuse foot process effacement all along right here.
What's your diagnosis?
So just looking, so the histopathologic diagnosis would be minimal change disease.
Yeah, so was there any evidence of interstitial nephritis?
No evidence of interstitial nephritis. I didn't see any interstitial inflammation or any cells or anything like that.
Or ATN, which we often see, and we talked about pathophysiologically. So, plain old, boring, never boring, minimal change disease.
The other thing,
Go ahead, Steve.
David, the vessels look pretty good, right?
Yes, yeah. Vessels were good.
Yeah, I mean, this is, somebody in this age group, they're the ones that, I mean, she didn't have acute renal failure, but older patients with acute renal failure in the series by Falk and Jeanette, they were more likely to have severe vascular disease, so that any hypovolemia would have a much greater downstream effect in causing ischemia. And so maybe that, since her vessels look pretty good, that kept her from developing AKI from nephrotic syndrome from minimal change disease, and as Dr. Glassick had suggested, intravascular hypovolemia.
Also sort of shocking because she had such severe CAD. You said 5 stents KC or something like that. It was really bad vascular disease in her heart.
Oh, good point.
I'd like to make 2 points. One, I think the best term that fits this morphology is nil disease. And the second has to do with what Helmut Renke has described, him and his group, which pertains to this anti-nephrin story, and the lack of this powdery appearance within the GBM is against the presence of anti-nephrin. So something to keep in mind.
That's a really good point. I hadn't thought about that. Oh, you want to defend your nil disease comment?
Well, we used to call it minimal change. The other term was lipoid nephrosis, which I wouldn't use because I didn't see this vacuolization characteristic of lipid deposition as a result of the massive nephrosis. And the other term certainly is nil disease. And obviously, we have a historian among the group, Dr. Glasser, who can extend that concept a bit more.
Well,
Go ahead.
I agree with what Dr. Rubin says, and in fact, I think we are now in a position where the old term minimal change disease is going to have to be discarded and probably replaced with a less definitive term like minimal change lesion with nephrotic syndrome, because minimal change is a pattern of injury, just like membranous nephropathy, and it doesn't define the pathogenesis of the disease. And now we know that there are many varieties of the minimal change lesion: antinephrin, Hodgkin's disease, lymphoma-associated disease, a non-steroidal associated. So establishing a lesion of minimal change does not define a disease. And I frankly think that maybe we ought to change our thinking a little bit and start calling this minimal change lesion in association with primary nephrotic syndrome, and leave it to others to define what the pathogenesis is. And immunofluorescence might help if you see the dusting of IgG that is apparently a biomarker of the nephrin pathogenesis. Now, in this case, the dusting of IgG was absent. So we really don't know what the pathogenesis is. Maybe, as Steve suggested, this patient has a lymphoma lurking in the background. We don't know. Time will tell.
So let me ask the team here. I mean, do you guys routinely do a lymphoma workup, as we might do a solid tumor cancer workup in PLA2R negative membranous, independent of the antibody, thrombospondin or NEL? Do you, in a 64-year-old with minimal change disease, do you routinely do a lymphoma workup? Let me ask around.
Yeah, I mean, in an older, in adults, I will do an LDH and, CT scan of the chest, abdomen, and pelvis looking for adenopathy, just to make sure I'm not missing it, because there's definitely obviously a different approach to those patients, and they can present just like this. So I'm not going to say I did it all the time, but I've started doing it more and more as time goes on, especially in the older adults. Obviously a good physical will find the adenopathy, but they don't always have peripheral adenopathy, and they can have it elsewhere that you might miss otherwise. And interestingly, you bring up the PLA2R negative. Keep in mind, Fernando Provenza's paper, when they talk about using PLA2R to basically diagnose membranous without doing a biopsy, they always have the caveat is that you've ruled out all the other secondary causes. I've always found that interesting.
Now, Steve, knowing that a neoplastic process may precede, may follow, or coincide with a lesion, you still feel urged to work an adult up for malignancy in a case of Neal disease?
Well, like I say, lymphoproliferative disorder. I'm more off. I mean, I wouldn't do necessarily breast cancer unless it was membranous. Not to say that these things can't coexist, but looking for lymphoproliferative Hodgkin's disease essentially, or non-Hodgkin's lymphoma, then I'll look for evidence to make sure they don't have it, because we know for sure some of them will respond, but many of them don't. That becomes, I guess, maybe if you have someone that's steroid resistant. Or not as responsive, it may make you search.
I agree 100% with Steve.
Right.
Most, but not all of the patients who have lymphoma-associated minimal change lesion are steroid unresponsive. So if you want to defer the workup, it's okay, I think, to try steroids first. But if they don't show a prompt response within 4 to 8 weeks, you have to start thinking about not only lymphoma, but thymoma, and perhaps some rarer cancers. But lymphoma and thymoma are the two big ones.
So Dick, you don't do it automatically. You'd want a little bit more to do it.
I would give the patient steroids, and if there was a very prompt response with a remission, that makes a lymphoma-associated disease highly unlikely. I think I would follow the patient, and I'd certainly do a chest CT, as Steve suggests.
Automatically?
But I think this patient's going to have a lot of chest X-rays in the
chart.
files, so I'd just be sure I looked at it.
Yeah,
So you would do it, so you would do a chest CT before you treat her?
A what?
A chest CT scan, you would do it before treatment?
Oh, probably not, Steve.
Okay.
I think this patient is uncomfortable, ill, has no lymphadenopathy, no fever. All of the features suggest no type B symptoms. If there was anything to suggest a lymphoma, including lymphadenopathy or an elevated LDH in the routine laboratory studies, I would definitely do a CT before starting steroids. But in this patient, I'd probably start steroids first.
just for the record, Dick, that was Roger, not me, that was asking that question.
Okay.
Steve's afraid to challenge you. Mario, would you,
Oh, yeah.
Mario, would you do a CT scan, or would you just treat, and then if something didn't make sense, you might look for secondary cause?
Yes, I wouldn't do it. I mean, I have wasted so much money over the years that I will probably do what Dr. Glasser has suggested, treat if there is no response by 8 weeks, knowing that adults lag a little bit in their response compared to children. Then I will work the possibility of a underlying malignancy at that point.
Yeah, so Steve, you would automatically get one.
No, what I said, I would get an LDH, I would do a good exam. I wouldn't hold treatment. I wouldn't hold treatment before getting it, but I would generally get it.
So you're hedging, but yeah, you would get it.
No, but let me put it this way.
I'm not saying holding treatment. Would you get it? You get it. You get
I
it.
would.
That's fine. I'm not criticizing that.
No,
I'm just trying to get an idea.
I would, and like I said, I didn't do that historically, but lately, especially because I have some of these older adults, you treat them and they start relapsing as you come down on the prednisone, much more than I would have expected. And then I start wondering, did I miss something? And so it's really because of that as much as anything.
Yeah, but people relapse all the time, and that doesn't,
They
make
do,
me
but
feel.
oftentimes not just with a short, as you're starting to slowly taper down. I mean, that's,
Yeah.
it's for me at least, it's always when I've gotten them down to 10 milligrams or 5, they might. And again, that's frequent relapsers or steroid dependent, and that's only, maybe 10, 20% or 20% or so of steroid responsive patients. But anyway, yeah, I mean, beyond the exam, I'll get an LDH for sure. And more often than not, I've started getting chest, non-contrast CTs of the chest, abdomen, and pelvis.
All right. Well, you have a second poll. It addresses a little bit of a different issue here. You can throw that up. So how would you treat this patient? And I want to put a caveat here. This patient's had a lot of bleeding. Let's just pretend that she doesn't have this history of GI bleeding, because otherwise there's kind of two questions here that I'm trying to address. One is, what would you treat the patient with? And secondly, would you anticoagulate the patient? So forget about the fact that the patient has bled a lot. Let's pretend she has no history of bleeding. Sorry, but bear with me. Would you treat her with prednisone alone? Prednisone with warfarin? Prednisone with a NOAC? CNI with or without anticoagulation, or rituximab with or without anticoagulation? So go ahead and vote. We have 0 votes.
Here we go. You should be able to vote now. Trying to make it tough.
I got worried. I thought it was so bad nobody wanted to vote. Get a few more votes in here and we'll put it up.
Right. There we go. That's 70%. Oh. Right. Results are up in the screen.
So prednisone's the clear winner, and it looks like prednisone alone is the clear winner. So I think prednisone is probably what most people would treat this with. I didn't get a single bite of CNI, which is probably a good thing. Rituximab, you know, that's for another day. It's not the craziest thing in the world. Considering 50% of patients will relapse, we don't know if it was used as primary therapy, if that would take that away. It's no joy to give another bout of a whole nother course of steroids, but let's use the rest of our time talking a little bit about the need for anticoagulation in someone with minimal change disease. So, Steve, what would you do?
Yeah, this is how I wrestle with this all the time with minimal change disease. I mean, they theoretically should go into remission relatively quickly now. They don't go into complete remission oftentimes until you get out to 16 weeks, but by 8 weeks, half of them have gone into a complete remission, and the other half have at least had improvement in the proteinuria, ideally to a level that the albumin should be above, I would hope, 2. As a result, people, the recommendation to put them on ACEs and ARBs is not to. The recommendation about putting them on statins is not to, because they will respond usually quick. The issue of anticoagulation is kind of another issue, and they are at risk of developing thromboembolic events. Historically, I didn't do it. I mean, in all honesty, membranous patients for sure, I would, because they were much more at risk of thromboembolic events, but for sure these patients can have it too. I know the caveat you threw out here is forget about her bleeding potential, because whenever you start, there is a tool that I think the group from Canada came up with on how to, deciding whether or not the risk of benefit ratio of anticoagulation is worth it. And in her, probably wouldn't be, given her bleeding potential. But say, in the absence of that, you can make an argument to do it. And do I do it always? No. In all honesty, her albumin's right around 2.
So you're the king of hedgers, Steve.
I know I am.
Would you do it or not in this case?
Yeah, I'd have to see her, but she seems sick enough that I probably would do it in her case. And
what would you give her?
prednisone.
Warfarin, a NOAC, aspirin?
Pardon?
What would you give her?
Eliquis.
Eliquis. Okay. Before I ask the person that's written more on this than anybody in the world, Mario, what would you do?
Well, I'm concerned about her bleeding story.
We're going to ignore that.
If she does not respond in some fashion by 4 weeks, I will probably bite the bullet and anticoagulate at that point.
Okay, so that's not unreasonable response. Of course, the issue is that patients might respond so quickly, but it may not even make sense to do that. And the other is, like Steve said, the thrombosis isn't quite the same as membranous, but clearly it's present. We've even seen, I think Casey had an arterial thrombus years ago in a minimal change disease. So it's not, and that could be catastrophic. So, Dr. Glassick, what are your thoughts about anticoagulating minimal change disease?
Tough question, Steve. Tough question. A very tough question. And I think Steve articulated some of the uncertainties that everybody has in this arena. I have tended to use more anticoagulants now than I did 10 years ago in patients with minimal change disease. I've come to appreciate the risk of potential catastrophic events. I wish I could say that I'm convinced that Eliquis solves all the problems of risk. I don't believe that that's the case. Warfarin is still the standard of care for prevention of venous thromboembolism and nephrotic syndrome, even though there never been a controlled trial of any of these drugs. Is there anything that I could use to sway me one way or the other? Well, if there's things in the history that suggest that she is at increased risk of a bleeding event, I would not do anticoagulation. In the absence of that, I think I would probably lean towards anticoagulation in a patient like this, at least for a short period of time. Now, I wouldn't use warfarin or Eliquis. I would probably use subcutaneous heparin and low-dose aspirin. I don't think there's any clear evidence that Eliquis or warfarin over the short term is superior to that regimen. And because I think this patient is likely to have a quick response to steroids, I would be content with starting with subcutaneous heparin and possibly low-dose aspirin, rather than oral Eliquis or warfarin. I'd like to hear the comments of Steve about the possibility of using that strategy as opposed to warfarin or Eliquis.
No, that's a good point. I mean, there was a paper out some years ago that looked at just giving aspirin, and if you started it early before they'd had obviously an event, that alone in patients who aren't too severely hypoalbuminemic, so we'll say their albumin somewhere around 2.5 or so, that they were suggesting aspirin alone. And I'd forgotten until you brought that up, just with giving aspirin, that would be another possibility. I have to admit, I've never done the sub-Q heparin. So you're talking like 5,000 units twice a day, or are you talking about using the low molecular weight heparin?
Low molecular weight heparin,
once a
day, subcutaneously.
I mean, that's clearly another option that would be there. I mean, I don't know. It depends on whether the patient likes giving themselves injections relative to taking a pill.
Right.
But that would be another option. I mean, it's funny, as we were sitting here talking, I was just thinking of a patient I saw today who came to me for yet a second opinion. I'd seen her a year ago, and this is somebody who has steroid responsive, essentially minimal change disease, who relapsed, and the indication that she would lapse was she threw a pulmonary embolus. So, as you say, it can happen.
Yeah, Dick, there's that, I have seen a paper that they use aspirin alone. I've always had trouble accepting that's enough to do anything. Do you think there's any role for aspirin alone?
No, I don't. And the only question I raise is, would it have an additional benefit when added to heparin? I would not use aspirin alone as a venous thromboembolism prophylaxis for a patient with minimal change disease and nephrotic syndrome. The question is low dose heparin versus warfarin versus Eliquis. I mean, there are no controlled trials, so it's all a matter of opinion and preference.
Well, you're targeting platelet function and antithrombin 3, basically, right?
Yeah.
And so you with the platelets, you prevent the plug from occurring, and then with the antithrombin 3, I guess you prevent from having it fibrose. So you're hitting two different mechanisms, I guess, related to the clotting. And so I would think that could be done. I see no reason why not. And again, the caveat being not this patient, really. I think from what I recall now from this woman was bleeding all the time. So I think you have a different issue in this particular patient, but in general, as Roger outlined to begin with, all comers without the bleeding diathesis. It sounds like more people than not would be willing to go ahead and anticoagulate, which was something, I guess what's the break point? Is it 2? Or is it as the group in Canada and New York or in Chapel Hill, North Carolina, when they merged their data where the 2.8 became the break point. Granted, there were only 7% that had thromboembolic events in that patient population, but they found that once you got below 2.8 grams per deciliter of albumin, your risk of a thromboembolic event went up. So what do people use, 2 or 2.8?
Well, that's only for membranous.
Yeah.
Well, they had other patients in their
but
studies.
the analysis was limited to membranous.
Oh, I thought they had a second paper that had more than just membranous in it. Okay.
I think there are inadequate numbers of patients and inadequate numbers of events.
Yeah. Okay.
To make any analysis of a threshold for minimal change lesion or FSGS.
I usually like to use 2.0 or less. I mean, because that makes the smaller number of people you have to treat in general, but obviously in minimal change, they're almost always below 2. So anyway.
So I'm going to move this
along the lines of what Steve said about the underlying pathophysiology of the hypercoagulable state. The low levels of antithrombin 3 that are observed in these cases, do that push you against using heparin in any shape or form?
Well, I guess you're inferring that a very low antithrombin 3 level would make heparin ineffective
Correct.
because it requires antithrombin for its effect. Generally speaking, I don't measure antithrombin 3 levels, and I just use empirically subcutaneous heparin. Obviously, I don't have a randomized controlled trial, so I really don't have an answer to whether a pre-treatment antithrombin 3 level would be at all useful in helping that decision. And I know of no paper that's examined that question, Mario.
It's a good question. It'd be nice to know if, you know, if that was somewhat of a predictor and we could use it to guide our therapy. It's a really interesting idea. You know, you imagine somewhere somebody has a lot of blood on stored on a lot of patients with minimal change disease, that could be
I mean,
looked at.
it's not just antithrombin 3, it's protein CNS activity as well, and we don't really measure those either. That's just one of the factors. But you know, heparin will facilitate whatever antithrombin 3 I assume is present, which still would be beneficial.
With the availability of INRs that patients can perform at home, the development of these clinics that supervise anticoagulation, I don't know. I prefer to stick to Coumadin myself, but anyway.
Well, of course, the problem with Coumadin is just what you said. If you have a good, reliable home INR test, it takes, you know, makes it infinitely easier. You can get a lot of tests done. You can manipulate it a lot easier. But having somebody come in all the time is a pretty big, you know, pretty big deal. I'm going to move this along. There's some stuff in the chat but I don't really want to get to that for lack of time. Casey, you want to tell us what you did and how she did?
Yeah, so I didn't get a chest CT on her. I started on prednisone, 60 milligrams. She did respond within 6 weeks.
Wow.
Her albumin came up to 3.4. Her proteinuria went down. And at this point, she's actually in complete remission off steroids for about 6 months. She has a normal serum creatinine, and she actually has undetectable proteinuria with no relapse. So I ended up not doing a secondary workup.
Yeah, so that's interesting. And you did not anticoagulate her?
I didn't anticoagulate. I haven't really been doing it in minimal change disease. You know, I'm sure that's all, you know, that's going to draw some comments, but you know, 6 weeks, it's still, you can have a venous thromboembolic event, but the response is usually so quick. And I have sort of learned that usually there's a much higher incidence in membranous and less so in minimal change. Doesn't mean that it's not going to happen. It's just that it's less likely. And if they respond quickly, I skipped it. And in this case, it was easier because she's had multiple hospitalizations with GI bleed. So that definitely helped me make that decision a little easier.
Do you remember off the top of your head, did she, you said 6 weeks, did she come down progressively or did you not have a lot of labs?
Within like 3 weeks, her swelling was better. So my interval for follow-up was every 2 to 3 weeks. So we had labs and exams and blood pressures every 2 to 3 weeks. So within 6 weeks, she was already, you know, beyond partial remission. So less than 50%. And by pretty much like 6 to 8 weeks, she was in complete remission. So she responded very quickly. Symptomatically, she got better much faster.
Yeah, and I think that's a pretty good clue, you know, that when patients, you know, sometimes I've had a patient tell me, start steroids and a week later they've had this massive diuresis. And I almost don't need to know. I mean, of course I'm going to get proteinuria, but you know, I've never seen that fail me. It's not because of diuretics. I'm talking about they get better very quickly.
And I always go back and think, what if this was the NSAIDs and maybe I could have just stopped it and watched her for 2 weeks, but she was so miserable and so sick looking that I said, we should just give it. In fact, I actually started her on prednisone 2 days before I biopsied her. I was like, she's miserable. Let me just start treatment. Worst case scenario, I can stop it after 3 or 4 days. So that's how urgently I wanted to start her on steroids.
Absolutely agree. Absolutely.
It's a little tricky sometimes to back off on diuretics in this situation because you know, you're keeping the diuretics going, they're so nephrotic, and then they're starting to respond, and then you don't want to volume deplete them on top of it. So it's tough sometimes.
I would go so far to say that diuretics would be contraindicated in a patient like this who presented with volume depletion and severe nephrotic syndrome.
Yeah, I think that's a good point. I think you risk a little bit with aces and arbs in that situation too.
Right.
Um,
Mhm.
this is a great discussion. It always starts out as, boring minimal change disease, but, we had a really nice talk about selective proteinuria. I learned a lot. Got some real interesting opinions on whether or not you'd work this patient up for lymphoma. And finally, a lot of opinions on anticoagulation. And that's what makes this great. I want to thank everybody for contributing, and also the people in the chat box. We will be off next week. Follow your email. If you're not on the email list, let us know. Until then, everybody stay safe, and thanks for contributing, everybody.